So today I am honored to have with me Dr. Jesse Jupiter, who is the Emeritus Hans-Georg Wyss Professor of Orthopedic Surgery at Harvard Medical School and a longtime faculty member at Mass General Hospital. Dr. Jupiter, to me, though, is the ideal and epitome of an AO surgeon and is the single greatest role model for me in the kind of practice I hoped to develop as a young surgeon and the kind of academic life that I still aspire to have. And so it's a great honor for me to have Dr. Jupiter today and to get to ask him some questions. So Dr. Jupiter, if you would just tell us a little bit about how you got started with AO.
Sure. Actually, when I was starting my orthopedic residency in 1976, AO was a nebulous organization and actually thought not very highly about. The concerns about operating on fractures were paramount to most of the attendings. And really give you a good perspective, we treated subtrochanteric fractures in traction, in 90-90 traction, and distal humerus fractures in olecranon pin traction. And that was the Mass General and frankly the American perspective of fracture care. The issue of AO came about for me when I was a junior resident. We had a fracture conference every Tuesday afternoon, attended by senior faculty who generally poo-pooed anything that was done invasively. Just to give you an example of that is one of them, when we started to do compartment pressure measurements described by Whiteside using a manometer and a long tubing, etc., and then released a posterolateral compartment. The point was that was meddlesome, and no problem. I've had patients with claw toes. They never complained. So that was the attitude. And along came a Swiss surgeon who was one of the founders of AO, Hans Villenegger. And there were two things that I can recall so vividly. Was one, he carried several boxes of slides. And second, the slides were of fractures. And not only were you visualizing the pre-op and intra-op pictures, but the post-op x-rays, and then every case shown had a functional follow-up.
Huh.
Among everything else, that's what struck me as unique. And so the AO, as it stood then, was really a group of surgeons in Switzerland who had organized a way of treating fractures that seemed to me personally to be pretty interesting and pretty successful. In those days as well, and nobody attending wise in the major hospitals and Harvard system were very familiar really with the nuances of internal fixation. So as residents, we graduated, so to speak, into our exposure by taking an AO course. Well, there were only two AO courses. One was in Ohio, at Ohio State. The reason being the head of the veterinary school was an interested AO surgeon, American. And the second was in Switzerland. And the AO people felt, interestingly enough, that you should become familiar with the equipment, learn the techniques before going to the OR. So we sat there, I will always remember in the evening, some of the orthopedic residents and I'm asking, where is a lag screw? I looked in the screw box, I don't see a lag screw. And that's how really unfamiliar we all were.
Wow.
What's that? And as
No,
we
I'm just trying to imagine Jesse Jupiter not knowing what a light screw was. It's just funny to me.
well, it was, and as we
There was time.
and then ultimately to become chief resident, where we ran a service for 6 months in those days, we started to do things. For example, my co-chief resident, Steve Neely, and I did the first IM nailing, closed IM nailing in the Harvard system. And we sat there and we had a crutch to support the leg. Everything was really by the seat of your pants. And there was, toward the end of the chief residency, I had an older woman who fell visiting her daughter in Boston. She was from Maine, very independent, and had an intercondylar distal humerus fracture. So I said, well, okay, we're going to put a pin in and put her in traction and do it. And then the anesthesiologist, say, okay, great, it's Saturday night and it'll go quickly. But it didn't reduce. It didn't even come close to reducing. And I said, we can't leave it like this. So then we had to re-prep and turn over and get the instruments. And, it was a big to-do. And I sat there reading the first AO manual. That's the only fracture we had.
Huh.
The anesthesiologist came over and was looking and said, are you having to read before doing this case? I said, I think that's a good idea. I have every reason to call your chairman, Henry Mencken, and tell him that his chief resident has to read before the case. Well, we did the case and the pieces were all over the place, but we put them together very well. And the anesthesiologist was mostly, of all the people in the OR, most impressed.
Huh.
And I mentioned Henry Mencken only because in New York, before he came up to Boston, he was chairman of the joint disease hospital and surgical center. And he had a surgeon who also was influential as an early user of the AO technique named Howard Rosen.
Mhm.
And Mencken called Rosen into his office one day, and I'm relating the story from Dr. Rosen. And he sat there smoking his pipe, which he used to do. That's Mencken. And he said, Rosen, I hate AO. And Rosen sheepishly said, didn't say anything. And he said, don't you want to know why I hate AO? And he said, okay. So Mencken said, I hate AO because it works. And what he was implying was that it was going to lead to, in the US, to a lot of open surgeries.
Right.
And he was prescient enough to realize that. And having said that, he became the biggest user of AO in the Northeast with all his tumor cases that he was constantly putting on these long plates.
Huh.
So at the end, or at least at the end of my residency, I realized that there was something to this, and I need to go to Switzerland. And I was able to get a traveling fellowship that Mass General used to have, and the AO had a stipend. And we went with 2 little children for 3 months. And you have to realize that I'm looking at things that I had read about, but had trouble conceiving. And I'll always remember the first week when we finally found a place to live and all that. It was within walking distance of the hospital in Basel. And I saw, as I was walking to the hospital, I saw a man walking with these two forearm crutches, slowly but persistently. And about 2 hours later, I'm in their fracture clinic, and there is the man, and there's his x-ray with about 5 different plates and screws on it. And, you know, with his motion being excellent, etc. And so I then realized that there was the people were telling the truth. And if you were over there, the other thing you realized was how careful they were with sterility. So the concern that, you know, there were going to be a lot of infections and all that was not the case. Part of it was the Swiss air, and and the other was the quality of the surgery. And most of the surgeons that I spent time with were actually general surgeons. So I would see this fellow Tom Rudy do a fractured tibia, and then a gallbladder or a thyroid, you know, on things like that, or Martin Algauer. And so what you learn from that, just visually, you didn't need to have your hands wet, was the soft tissue approaches and the necessity to balance, you know, your open surgery with the soft tissue care and preservation of blood supply. So I realized that this is a good thing, and I learned quite a bit, and I did some research there. And the other major impact of the AO, which really was not well appreciated for quite a time, was outcome data. That every patient that was treated in one of the AO hospitals, there was a secretary who recorded their information, and they had computer cards which had the x-rays of the pre and post and follow-up x-rays. And if the patient was followed up for 1 year, and if the patient was living in Switzerland and didn't come, the police would go and get the patient back. So the documentation was not only thorough, but it was honest. Okay. So when I looked at these computer cards, I realized that there was a wealth of information that you know, really needed to be in publication form in North America. Because the roadblock then, besides the lack of familiarity and lack of really belief, was the Journal of Bone and Joint Surgery and affiliated journals. They didn't believe it. And so some of the editors strongly rejected papers. So classic papers that ultimately got published in secondary journals were rejected because of their feeling that they weren't telling the truth, and etc. And when I
and sorry, I just
go ahead.
And that's because the results seem too good to be true.
Yeah, well, to a large degree, yeah.
Right.
So when I did this project, I did on distal humerus fractures. That's where I was, because of my really send-off from Boston, was this distal humerus fracture. So I looked up, I would take the train to Bern, the documentation center, and spend a day looking at files. And then I wrote the paper with Martin Algauer and Pietro Regazzoni, and one of the registrars got follow-up. So every patient, not only did we have follow-up for the cards, but they got follow-up from all those living in Switzerland. in a longer term follow-up. And ultimately in 1985, it was published. And that was a seminal publication for the AO because it just proliferated from that. And secondly, people started to take these fellowships like I did, and they were starting to filter into and populate North American centers. So people like David Helfet and others all did the same route and followed through with their experience and then teaching and then credibility. So then I, because of that, I felt fairly comfortable with understanding the biology and biomechanics that internal fixation brought about. And when I did my hand fellowship in Louisville, Kentucky, that topped off the soft tissue and, more creative microsurgical techniques that all balanced through. And as a result, I felt fairly comfortable in taking care of most trauma, that lower extremity, upper extremity. I stayed away from the spine and pelvis, but otherwise, for a certain number of years, I would take care of everything and then branched out to reconstructive, not acute trauma. So it's a lifelong experience, as you mentioned, but it certainly influenced myself and others in that era. And the final thing about the AO, people use the term a family. And because of the international nature of it and the fact that AO courses were then being held in various places in the world, as faculty, we became quite friendly with many, many people and many, many associations that remain today. So it occasionally has been nominated for a Nobel Prize, and to a large degree, it's probably deserving because what its impact was on changing the perspective. And one final thing was when they started it, they decided that only 4 or 5 surgeons would use this technique, and they would gather the data and then go about, trying to publish it and whatever. And the Swiss Surgical Society was also somewhat reluctant to accept it. But then when they presented it, it was met with a great deal of enthusiasm. And you have to understand the population in Switzerland too. They don't want to be disabled. You see these older age patients, taking train rides to go cross-country skiing somewhere in the Alps and don't think anything of it. So the Swiss what's that?
It's I was going to say it's a nation of Jesse Jupiters.
It's a Swiss National Insurance Company really was not happy with the conventional management after the Second World War with CAS and traction, and they also were very supportive of this approach. So it's quite interesting, and now it's somewhat standard of care, and the difficulties come about when people have become exposed early on to the techniques, but not in an evolutionary way to the soft tissue and biology aspect of it, so that there still remains probably too many complications.
So sort of carpentry versus biology.
I think so.
If I could ask it just a follow-on question, so that if I were to think of it sort of in chapters, you've described sort of the opening chapters of of AO in North America, just to a real extent through your own involvement. And I have some sense more of the later chapters, but I'd like to ask about the kind of middle chapters. You know, what were the later 80s and 90s? And I know you did fascinating things. You were involved in implant design and in figuring out how to scale up education in AO. And I'd love to hear a little bit more about the middle chapters, if you could.
Yeah. Well, yeah. In the AO people, well, you have to realize that they also were commercially oriented. So if there were problems and solutions could be achieved, or they were very supportive. So on one sense, in the hand world, some of my colleagues in Switzerland were asked to form a little group to try to solve some problems, and really have a lot more support to do this. And that's where Hans-Jörg Wyss comes in, because he, as a head of the manufacturing division of the plates and screws and all that, was very sensitive to that, the need for that. So we used to meet both at national meetings and by, there weren't emails in those days, by phone, and try to solve some problems. And for example, the distal radius, there was a lot of difficulty in operating on osteopenic bone. The screws, didn't really function very well. So we took the early development of the locking screw from the maxillofacial group and then developed it into the plate and screw system that was the first in the distal radius. And actually, I, to a little degree, influenced George Orbay into taking that design concept and applying it, because we did do it on the bowler side as well. And we did a wrist fusion plate, when I was a resident, and up to this time, most wrist fusions were done with a bone block from the iliac crest and K-wires and 3 months of cast. And we worked on a plate, and it worked out very well. So we had an opportunity to pursue these sort of things, and they were the organization was very sensitive, which made it very nice. We were not getting royalties, but expenses when we traveled and things like that. But it made it even nicer in a way. And then, of course, it led to education. And so I realized on the second note that Mr. Wyss was also, he's a brilliant businessman, and could see the value of education, because the better the education and the ability to expand it worldwide obviously helps everyone. Patients, have surgeons, and the companies. So ultimately, I became the head of the AO International Education Board, and found a lot of creative ways of running courses. It's just amazing. You were given like a boy in a candy shop. You have an idea, let's do it. And so we developed a lot of, which in those days was somewhat different educational vehicles for providing the ability to learn these techniques and understand it. So that's what I was doing with the AO for a number of years, and continued as faculty worldwide as well. And so it was a very positive experience, and it led to being a head of the International Education Committee of the Academy and other areas as well.
Hmm. That makes me think in both in both areas, both in the implant design and the sort of business of trauma care, but even more interesting to me, the education. Things have changed and evolved quite a bit in the last little while in education, for sure, since the COVID pandemic and shutting down all of the international and national in-person courses and then building them back up has really given us a chance to sort of rethink how this works. And I'd love to hear what your advice would be for those of us who are involved in that redesign or in teaching. What should we bear in mind? What can we learn from you and from the past that we should not forget as we evolve education in AO?
Well, we're conflicted now because our views of life are continuously evolving, and where work and family life and going outside of work to do things related to that field come into play. And I think one of the challenges today is trying to accept the fact that it's not a given. You have to give something up to do these things. You have to give up time, and by that virtue, perhaps your family and other aspects of it. So I think people need to make some decisions early on in what type of professional life they want to lead. And if you chose academic life, then, you know, you have to be committed time-wise. And to some areas that may mean some impediment in your economics.
Mm-hmm.
You know, if you are going to do these things and take extra time for teaching and developing education programs and all this, and you know, it may take away from other aspects of your academic life. So I think early on to make a commitment is very important. But once you do that, it flows. There's really a certain personal sense of satisfaction and accomplishment from educating others, and it's a worthwhile endeavor, but it's not for everyone per se.
That's fair. Looking back on your time with AO, is there a single thing that stands out to you as the thing you're the most proud of?
Yes. When we started, I hate to use the expression, but these AO leading surgeons were like gods. You know, they were it. And when you mention their name, Martin Allgauer and Tom Rudy and stuff like that, it engendered a sense of accomplishment and respect from others, you know? Mm-hmm. And the singular sense of accomplishment, or the thing that would stand out, was then to not only be part of this family, but then to be accepted as a contributor and, if you will, an advancing member of the group and an expert, if you will. And so when you have that time in your life when all of a sudden you look around and these people are asking you, what do you think? And when you're presenting, even at the international meeting of the AO people, something that's a little different, but they come up and say, that's really good. That's, that's good. So that there's nothing better than that. It's kind of like I used to say when I started doing Ilizarov, I used to make the analogy of baseball. And when you start doing it, you're in pony league. It's really it's a very difficult thing to master. And so at some point I said, well, I'm in AA ball.
Wow.
And so in with the AO, I at some point got the sense that I was in the major leagues. And that's probably the sense of accomplishment.
That's a great analogy. Yeah. Well, that may be a good place to wrap up. Jesse Jupiter making it to the major leagues. Of course, it's fun. It's funny for me to think that you ever weren't, but of course everybody learns and grows.
Sure.
And I actually remember when I was your PGY2 resident, and I was moving through an operation so like carefully and slowly. I had prepared, and I was moving sort of slowly. And I apologized to you that I was going slowly, and you said, I was like that one time. I was like you one day, and I'd rather you were slow and careful and well prepared than slashing. And I thought, all right, Jesse Jupiter can tell me he was once slow, then I'll take my time and learn it right.
One thing I recently did, we had a rainy week here in Colorado. So I sat down and just looked at different talks and different cases, and I put together what I thought were creative solutions to some difficult problems. And I made a view medi that I think just came out. So if anybody is interested, it I think shows the expanse of types of problems that you can take care of with this better understanding of the basics, so to speak.
No, I look forward to seeing that.
Yeah, it's I think on the web already. Okay,
well, Dr. J, thank you so much for your time today. It's great to see you. Great to hear some stories.
You're looking well rested since you passed the baton.
Yeah, it's it's nice to have time for things like this.
Yeah,
so
exactly.
I'm very satisfied with the change.
Good.
All right.
Take care, everyone.
Take care, and thanks so much.
Bye-bye.